So, as I say, I'm not Ben McNaughten, but I'm Rory Sweeney, and also along with Ben and the other names there, I'm going to talk about ACTup, which was a course that we devised and ran in the Children's Hospital in Belfast, which was helping to prepare senior paediatric trainees for challenging clinical encounters. I'll go a bit through the background and just kind of how we set the course up, and then some of our feedback from it. So, over the last number of years, there's been an increasing emphasis on communication, interpersonal skills, or so-called non-technical or soft skills, however you'd like to describe them, which is right, because, as we all know, the majority of the complaints that come in through healthcare are often to do with the interaction of staff and the communication with staff and patients. We, as paediatric trainees, we identified there was a lack of opportunity to develop some of these communication skills, particularly in challenging circumstances, because paediatrics, maybe more specifically than some other areas, is very consultant-led. So the first time that you are there to take the lead in some of these very difficult situations in paediatrics is when you're suddenly a consultant and you've never had any practice in it. So we noticed that there was a lack of simulation-based training generally around safeguarding and child protection. And the feeling for this was that it's quite difficult to set up simulation around these challenging situations, because it's not necessarily a high-tech area that you need to look at. It's got a different feel to it, and something else that you need to bring to communication simulations to make them engaging. From a bit of background, there's been a bit of research into what kind of affects the reality of a simulation. And some of this research has tried to divide it up into three areas that you kind of look at, which are involved in the reality of a simulation. First one is the physical environment. So you've got your mannequins, you've got your clinical area, the staff and stuff who are present, which kind of gets you into the mode that, yes, this is a clinical situation that's actually happening. The semantical mode is more the relay of information. So this can be done in various ways in simulation. Sometimes somebody will just verbally tell you what the oxygen saturations are, for example, or more and more we're moving towards higher fidelity semantical mode, where you have a monitor there. When you ask for certain things, they will become apparent, or you have to attach monitoring. You've got sounds, you've got numbers, and those numbers change, and that allows people to engage better in the simulation. It's more like a normal clinical situation. Sometimes the area, the third area is the phenomenal, as it's referred to, and this is more how the scenario feels, or the emotional feeling of the scenario. And we felt that this was kind of the most important area when you're talking about these high intensity, sort of challenging communication situations. And this is the bit that we often get or have a problem with. So, just at the time when we were beginning to develop this, Ben had seen some work that Dr. Paul Murphy, who's sitting in the front row here, had been doing with the Belfast University School of Drama, and he was running a course where he was trying to develop improvisational acting techniques and bring them into healthcare simulations. So rather than having a standard simulated patient who you give a script to and they follow the script, these guys are able to bounce off and react to what happens in a given clinical situation. They work by a system of actor training, which is known as the Stanislavski system. So Konstantin Stanislavski, he was an early 20th century Russian dramatist. It might have been late 19th century, actually, was he? Yeah. Who kind of developed a move away from the art of performance, which is what actors did at that time. They stood on a stage, they projected the script that was in front of them very loudly, and didn't take in an awful lot of the emotion that was required for the situation, and tried to move this towards what he called the art of representation, and thinking about, if you were that person in that scenario, how would you react? So giving the actors a brief, allowing them to develop their own character who would respond in a human way, and getting them just to rehearse through things, so that whenever it actually came to the performance, if somebody said a line that was wrong, the other actors are in role, they can just react appropriately to how that person has played that character, rather than the whole thing falling to pieces because somebody got their line wrong. So in developing the course then, we ran it first time in April 2017, and the scenarios were all worked through with the drama department. They were all based on situations that had come through, or similar types of situations that had come through the Children's Hospital in Belfast. We kind of divided it up into two types of scenarios. In the morning, we looked more at safeguarding type situations that we see in paediatrics. And in the afternoon, it was more about sudden unexpected deaths. The actors were given a brief of the characters who were involved. So there was two actors in each simulation. Usually it was a mother and a father, but there was a mother and an aunt in the fabricated illness situation. And they were told how the scenario would go as an overview, but given no script and no particular way that they had to play it. And they just brought their character to the simulation, and we put our trainees into it. Because of the kind of stuff we were doing, and because we were looking at getting these guys to have a bit of practice before consultant level, we were aiming it at our senior paediatric trainees to try and be able to allow the actors to really push it as much as they needed to. In terms of faculty that we got around for it, so we had a couple of paediatric consultants and trainees, a paediatric nurse, practitioner. We had a psychologist from the School of Psychology in Queen's, paediatric social workers, and Paul was there from the drama department. As it turned out, though, the actors themselves were probably the most important part of the faculty. So we were trying to create a communication course, and they were able to get involved in the feedback in terms of they were the patient's parents or carers, and how did this trainee's interaction feel to them, from the point of view of, was the body language right, how was their tone, how empathetic did they feel that they were. And they were also then able to teach us a little bit about the system itself, and how we might be able to have that in our minds if we're having a difficult conversation with a patient, parent or carer, to better understand how they are reacting and why they're reacting in that way. Can we put ourselves in their shoes and understand that they're not angry with us, they're just scared, and help to improve our own empathy. As is often done in these courses, we give a questionnaire to try and give us some quantitative information, but actually it wasn't the main focus of the course. So people did find that the sessions were valuable and that they had a bit of improved confidence in making these decisions. But a lot more of it was this sort of soft feedback that we got in terms of the specifics of how they reacted whenever the parents did a certain thing, and how they de-escalated the situation. So we got slightly more information back from our debriefs and our focus groups, and the trainees seemed to take from it what we were hoping that they would. We were putting them in a knowingly uncomfortable situation. Nobody wants to be dealing with the parents of a child who has just died and having to explain to them that you have to call the police and speak to the coroner, and they can't go back to their house because you have to go and collect evidence again. But that being able to have that conversation in a safe space whenever you're a registrar and you're training is better than having it for the first time at 2 o'clock in the morning when you're being called in as a consultant. The actors were universally praised, and their ability to react to the situation. So if a trainee was doing extremely well and was very, very empathetic, we had set up one of the scenarios that the father was meant to really get ramped up and start threatening really violent behaviour. But one of the trainees was just so good and calm throughout that the actor said at the end of the scenario, was like, I kept trying to get angry with you, but I just couldn't actually bring myself to do that because you were doing such a good job. And I think it's nice for trainees to know actually that they're that good in those situations, because you're never able to get feedback from a parent following any of these situations. So it really brought something new to our guys. So we have fortunately then been able to run this course going on. We felt that it was innovative in the use of these actors trained in these improvisational techniques, and that really trainee engagement was at a really high level. I don't know if anybody was up at our workshop that we ran there in the last session, but we've been through one of the sudden infant death scenarios in front of the group that was up in one of the workshops in it, and it is very powerful. And the whole group was kind of stunned silence. I was being the person leading the conversation, and I'm still a little bit shook up from it. So it is really engaging, and even in front of a group of about 40 people looking on, I kind of forgot there was any audience because you're just engaging with these actors who are just such a high level. We're running another course in March of this year, and we're going to keep expanding it and try and make it a mandatory piece of training for our trainees coming through in Northern Ireland. And that's it.